My name is Arlene Barrett. I'm one of the nurse practitioners for the neuroscience program at Florida Medical Center. So, yes, we did have an interesting case February 14th, and yes, I did think it was a squirrel. I admit that. But as I go through it, upload it up.
It's up there, and you can switch with the arrow.
So, this gentleman presented on February 14th. He is a 57-year-old black male who came in as a walk-in stroke at 1432 in our emergency department. He presented, interestingly enough, with bilateral acute hearing loss. He said, well, it started about 1 o'clock. He was equivocating a little bit about the time that he started, but eventually he settled down at about 1 o'clock. At baseline, he is hard of hearing, so he didn't think anything of it initially, but then he realized he absolutely couldn't hear anything. He had some aphasia, but that was hard to figure out because we had to write everything down, but he reported the next day that he did have problems reading what was there. It took time for him to put it together. His previous medical history includes, like I said, hard of hearing. He had a previous stroke about 9 months ago, atrial fibrillation, renal disease with dialysis Monday, Wednesday, and Friday, as well as high blood pressure. It's a pacemaker with a left arm fistula. He's on Coumadin, but he was subtherapeutic with his INR, as you can see, at 1.4. He was also taking aspirin. Secondary to his presentation, and I will freely admit some strident discussion about whether he was truly a stroke or not. After having a CTA and CTP, we opted to use TPA and send him to intervention. At that time, Dr. Miskolsky was covering us for intervention at Florida Medical Center, and he's like, no, there's an occlusion. So we triple scanned him, and the CT was negative for hemorrhage, so we were okay with giving TPA. The occlusion showed a left MCA division occlusion in the temporal parietal lobe. Perfusion showed hyperperfusion. And Dr. Miskolsky was kind enough to make sure we got the right slides up. So as you can see, he has an old stroke on the right side. Then there's a hypodensity noted on noted there, suspicious for a clot. This is his CT perfusion. So sent for cerebral angiogram and thrombectomy. The patient reported the next day that upon completion of his angiogram, he started hearing a little bit better and improved overnight. Now, mind you, he had no focal deficit. He drove himself here, which I was like, you did what? You couldn't hear anything. He's like, no, I drove myself here. I know I couldn't hear, but I knew I had to get to the hospital. So he got to the hospital, drove himself in, no focality, none whatsoever. So that's why the debate was there, because acute hearing loss is not a common presentation. I've never heard of anything like that in my time. So, but the CT angiogram, there you go. I mean, he has a big blockage there. And this is Dr. Miskolsky's handiwork here.
Oh, to explain, this was basically an angular artery, so a very posterior branch of the sylvian fissure, and you can see the occlusion on the left side, and on the right side, it's already open.
And because we did not do an MRI secondary to his pacemaker, this is a CT post-intervention. It's beautiful. And he had the thrombectomy, TK3 reperfusion. He was eventually discharged home with self-care. Again, he had no focality up on presentation, and he was back to his baseline. So.
This was one of those cases where the patient improved immediately. Literally, when we took him off the table, he was able to make a conversation when previously he was just like completely deaf, or acted like completely deaf. But this is not why we brought this case. I think this was a brilliant case where during the triage, someone recognized that, no, this guy is not crazy, this guy is not really deaf, But this guy has actually sensory or receptive aphasia. I guarantee that if this patient goes anywhere else, then probably an ENT surgeon would be called to this case in the afternoon, or even worse, a psychiatrist.